So we are going to go ahead and get started. Welcome everybody to the webinar Orthopedics, Learn What You Need to Know from New York Presbyterian Brooklyn Methodist Hospital. Does joint pain affect your quality of life? Are injuries keeping you from training at your best? And when should your child see an orthopedist? Today we have experts in pediatric orthopedics, sports medicine, upper body, and more. We're going to discuss their specialties, the integrated practice and comprehensive surgical and non-surgical services now offering for children and adults. And it is certainly my pleasure to introduce our prestigious panelists. First, I'd like to welcome Kumar Kadiyala, MD, PhD. He serves as the Chief of the Orthopedic Service at New York Presbyterian Brooklyn Methodist Hospital and is a professor of orthopedic surgery at the Columbia University Irving Medical Center. Dr. Kadiyala specializes in non-operative and operative treatment of chronic conditions and musculoskeletal injuries affecting the hands, elbows, and shoulders in both adult and pediatric patients. Welcome, Dr. Kadiyala. Next, please welcome Christen Russo, MD. She's an attending pediatric orthopedic surgeon at New York Presbyterian Methodist Hospital and an assistant professor of orthopedic surgery at Columbia University Irving Medical Center. She specializes in treating pediatric trauma, hip dysplasia, conservative scoliosis, and foot, ankle, and limb deformities in pediatric patients of all ages. Welcome, Dr. Russo. And finally, please welcome Sam Velde, MD, MPH, PhD. He is an orthopedic surgeon at New York Presbyterian Brooklyn Methodist Hospital and an assistant professor of orthopedic surgery at Columbia University Irving Medical Center. He treats all aspects of the lower limbs, including child and adult hip preservation and minimally invasive anterior total hip replacement. Welcome, Dr. Velde. So I did not lie when I said we have a prestigious panel here of specialists with us, and I am so honored to have you join us. So let's get started. Dr. Kadiyala, can you share about the scope and breadth of the practice at New York Presbyterian Brooklyn Methodist Hospital?
Of course. Thank you, Elizabeth. And thank you for joining us on this wonderful 90-degree day in New York City. One way to look at the orthopedic service at Brooklyn Methodist Hospital is we cover everything. All of you are sure very well acquainted with orthopedic maladies that require total hip or total knee replacement. Some of you may have had that done already on yourselves. So that's something that has a very long tradition here at Methodist and is ongoing. We are one of the busiest joint services in the borough. And if you think of orthopedics itself as a subspecialty, we have various niches within this discipline. Trauma or fractures, something that is readily taken care of. The routine fractures, if you slip and fall, to the more complex fractures with a motor vehicle accident. So we are a level 2 trauma center. So many of these traumas from the surrounding neighborhoods in the borough come to us. So both the simple slip and falls as well as the more complex injuries. Sports medicine, obviously a very important and very popular discipline for all of us aging athletes. I think everyone else on the panel is not quite aging yet, but I put myself in that category. So for all the things, the sports-related injuries, the training injuries, whatever we need to do to get you back to function. And I also want to emphasize this covers all ages. I have two experts on the panel, my colleagues who take care of all those small children. I take care of babies as young as 3 months old, all the way up to full mature adulthood. I sort of laughingly call it, we have the cradle to the cane practice. All ages are covered. And with this, any malady from the neck down to the big toe is covered by orthopedics. We have fellowship trained surgeons. We have the three of us have the academic bent in terms of how we take care of orthopedics and what we do outside of our clinical practices. So this part of orthopedics is flourishing at Brooklyn Methodist Hospital, and we're looking forward to the future as we build from here.
Wow, that's really fantastic. Such breadth. It's almost silly, this question, but still, I'd love for you to share with me, Dr. Russo, what else makes this orthopedic practice so unique? I mean, obviously, Dr. Kadiyala explained the breadth of and the scope of your ability to help people, but what else can you share with us?
I think you have to look at it from the perspective of Brooklyn as well. Brooklyn is a borough of families, it's a borough of children, it's a borough of community. And if you would look at the population of Brooklyn, we would still be the sixth largest state in this country if it was by population. So when you think about that and think about the resources that we should have available, it should be the same as, most of the 50 states in this country. And I think that we kind of have finally arrived there. The advancements that are being made at New York Presbyterian and Methodist in particular, and especially when it comes to orthopedics, are really kind of world class at this point. So we've always had a presence in different neighborhoods in Brooklyn, and we still do. We see patients by the Barclays Center, so serving more downtown Brooklyn, Fort Greene area, also near major transportation hubs, so Lower Manhattan as well. There's kind of avoid a pediatric orthopedist in that area. We also go out to Kings Highway in the Marine Park, Mill Basin, Midwood areas of Brooklyn that are also underserved. Kind of the crown jewel that we've been developing over the last 5 to 10 years, if you've been in Park Slope during this time, is a Center for Community Health. And that's located right across the street from the hospital and has kind of everything that we could want and imagine when it comes to orthopedic care. And we're so excited to be in our first 6 months of practicing there. The opinions that we've gotten from patients when they come in, they just feel taken care of right away. This idea of there's no need for a waiting room anymore in medicine, which was kind of born pre-pandemic, but definitely we saw the need for that during the pandemic. Exists here. You are greeted as you walk in, you're brought up to the floor, you're immediately taken to the exam room or to the x-ray suite, and you're really in great hands at all times. And so we're excited to bring that to you and encourage you, if possible, to make your appointments there. And besides our offices there, we also operate there. So Dr. Kadiyala does a majority of his cases there. Myself and Dr. Vandervelde is a little bit more limited. Patients have to be above 2 years old, but we can do a lot of our cases there as well. And again, it's kind of the same service and this concierge boutique medicine that you probably think you would find across the river, now here in Brooklyn. I also think that, to segue kind of what Dr. Vandervelde is going to talk about a little bit more, we really collaborate with each other and with other specialties as well. So if I'm seeing a patient that I think would benefit more from Dr. Vandervelde's care or also needs Dr. Kadiyala's care, we can immediately set up that appointment and know that there's a flow, or sometimes they're even in the office or in the operating room the same day, and we can really make that connection. We also work with non-operative specialists, so including physiatrists as well as physical therapists, and being able to work hand in hand and communicate with them is just really important, and something that we really didn't find in Brooklyn before this.
It sounds extraordinary. I mean, the word that kept coming to my mind when you were discussing it was luxurious, which is not a word you really think of necessarily when you think of a hospital, but from this concierge service that you provide to people, it means a lot, both from feeling comfortable and also from the expertise and what you said about how managing the full person, their full care, then being able to be in one place and you be able to access the individuals that they need to help them best. That's really, really unique. Thank you for sharing that with me. So Dr. Vandervelde, I do want to turn to you to dig into letting us a little bit know what exactly is sports medicine. Dr. Kadiyala talked a little bit about us aging athletes, and I'll count myself as one of them, but can you share more about that?
Sure. So thanks for the introduction. And then there's not a whole lot I can add to the service description by Dr. Russo and Kadiyala. The sports service encompasses basically any non-arthroplasty service that we can offer to patients. So where traditionally the wearing down of the joints is treated with total hip or total knee replacement, and it's been going on for quite some time. What we now also offer is the whole spectrum of what I like to call joint preservation rather than sports surgery. Joint preservation includes any athletic injury. It can be a ligament rupture, cartilage defects, but it also encompasses any abnormal joint pain, loading because of hip dysplasia or a abnormal stance of the knees. So what I offer is the whole spectrum of sports-related treatments, that you would expect at the academic centers across the river, but also all the variety of osteotomies, minimally invasive treatments to basically bring any person back to the activity level that they desire. So you don't have to be a top athlete to receive the top athlete treatments. Every patient has certain desires, and our role as orthopedic surgeons is to try to find out what you as a patient want and how we can help you in getting there. That doesn't mean always surgery. So when I see patients, like Dr. Russo already mentioned, sometimes surgery is necessary, but very often I work together with one of my colleagues at the rehab center, and together with physical therapy and sometimes local injections or modification of activities, we can get the patient back to their desired activity. If, however, we hit a wall, then what I can offer here at CCH and as well as the main hospital is the state-of-the-art, newest possible treatments. I am, besides my clinical practice, also involved in academic research. I'm on the editorial board of the American Journal of Sports Medicine, which is the leading journal in the academic field for sports medicine. And so together with my academic colleagues across the country and actually the world, we continuously try to improve the newest techniques. And I apply those right here in Brooklyn.
Wow, that's really important to know that you're in good hands, that you have the latest and greatest in being able to help people. And again, reiterating that you're working with along other doctors and individual specialists that can help the patient exactly the way they need to be helped. It's not a one size fits all. Thank you for that. So I want to talk a little bit about the pediatric specialty, because you mentioned before that, many of you handle people, as you said, from the crib to the cane, which is a great way of putting it. What is important about a pediatric specialty and the specialists? I wanted to hear a little bit about that from Dr. Russo and Dr. Van de Velde. Dr. Russo, do you want to start off with that?
Sure. As you may hear some crying children around me right now, as I'm currently in Park Slope, live. It's very fitting. And that's part of it. Pediatric orthopedics is not like traditional orthopedics where we focus on one part of the body. And I know Dr. Kadiyala does not take offense to this because he is more of an orthopedic generalist than any of us. But most orthopedists focus on one part of the body and go in and everyone becomes a knee or a wrist or an ankle or a spine. And in pediatrics, it's really the whole person, the whole body. And more importantly than that, it's also the whole family. And when we talk about holistic care, it's really not just the holistic care of the patient, but it's about the whole environment that's created. And, surgery may not be the right time because of things that are going on in school or at home or stuff like that. And I think the pediatric orthopedist pays attention to that and uses that to kind of focus on how to move forward and know what treatment options are available. In the more community sense. In the more technical sense, we have special training in growing bones. There are some procedures that are different between adults and children because children are growing and we have to respect that aspect of things. Most adult orthopedists, probably besides Dr. Kadiyala, if there's an open growth plate, do not even want to know about the patient. They just want to send them immediately to a pediatric orthopedist because they get so nervous about growth plates and what exactly happens with them. And we feel comfortable with that. And we like to be able to follow our patients to make sure that nothing goes wrong with that. It's more of a long-term relationship than just right after the injury, which I think is something else that we enjoy. And my area of interest, where most of my research is in pediatric bone health, which is really becoming more of a hot topic these days, especially as during the pandemic, we stayed at home more and we're outside and are worried more about nutrition and vitamin D. And I think that is something that, the pediatric orthopedist is becoming more familiar with as well.
So is that something that you should be thinking about with your children? I know, as a woman and as you age, it's something that's kind of drilled into your head that you need to think about that. But, talking about children, is that something that all children should be thinking about, that we should be thinking about their diet and how we can ensure good bone health from a young age?
I personally think yes. And I also think that it's a lot to ask of the general pediatrician to bring all of these things up at the annual pediatrician visit. I mean, I have two small children myself, and sometimes my own head is spinning in the pediatric office. So I can't imagine adding one more thing onto it. So I think that we have a great soapbox to stand on and speak about that. And I try to bring it up with all of the patients, regardless of their age. So I think that is something that is definitely coming to the forefront and we should be more aware of. And it's very simple education. It just has to be given.
So what would you recommend? Now I have to know, I have children too. What, and I'm sure many of our attendees do too. What would you recommend from a diet perspective for our children to protect their bones?
Sure. So I try to go over some calcium-rich foods, and in general, kids usually have a great level of calcium. Most foods are fortified in that sense, and especially kids in the perk slope population, they generally eat very well. But the vitamin D is a little bit more of an issue. We get a lot of vitamin D from the sun, which was not a great factor this past 18 months. And I often tell my patients, it's really hard to get vitamin D unless you eat like a bear. So unless you eat salmon 3 meals a day, it's really hard to get it from your diet alone. And so I do recommend some easy supplementation. I have a list I provide in the office. They're kid friendly. Everything can easily be purchased. And I think really having that direction, leaving the office with that information, it makes parents just, it's one less step they have to get to kind of understand what they have to do to supplement. So providing that information, I think, is a really nice feature of the practice.
Absolutely. Thank you for that. I certainly appreciate it. Dr. Vendeveld, can you share a little bit more about the importance of the pediatric specialist?
So I think, again, it's a very comprehensive specialty. So unlike some of the other fellowship trained colleagues, we during fellowship learn to take care of the entire patient. Every joint, every chronicity, acute, chronic, will be seen. For me, it helps to have the pediatric orthopedic background, even in treating my adult patients, because maybe it's the sort of push to think of it long term, as in how can I preserve the mobility with the least invasive possible way to keep the patient active, thinking about the future. So what if I have a patient with a meniscal tear? The easier solution is to remove the meniscus, but the long-term effect is joint degeneration. And so just like in children, every patient for me is almost like a child, and I try to maintain whatever is there for as long as possible. If I see someone who's 40 years old with beginning joint degeneration, but the alignment is off, because of my pediatric training, realignment is something that's part of my toolbox. And once you realign the joint back to normal, the abnormal loading that leads to degeneration will be resolved. And so I push off. So I like doing prosthesis, but I like not doing them better.
That really is a great point as to why it's so important, why this mix of knowledge is so valuable. I never thought about it that way. You're so used to seeing, this doctor for adult, this doctor for pediatric, but I can see the benefits of seeing a doctor that knows both.
So for example, if you allow me to talk about hip dysplasia.
Yes, please.
Abnormal development of the socket of the hip joint. Since I treat the entire age range going from 0 to 100, I can tell patients what will happen if you go down one road versus another. What will be the expected results if you miss a mild hip dysplasia at an earlier age, what the options are when you're 18 versus 40 versus 60.
That's a very good point. Thank you so much for that. There are a lot of myths about, orthopedics, and I really want to have an opportunity to clear up some of those myths and get myth versus fact. Dr. Kadiyala, you want to get started with that? Can you address some of those for us?
Sure, I'd be glad to, Elizabeth. But as a preface to that, I think just want to point out what my young partners just outlined. it gives an example of what we are as orthopedic surgeons. We don't just see a broken bone and fix it. We don't just look at an MRI and say you need surgery. We actually look at the patients, we examine them, we listen to them, and we advocate for them. What Dr. Russo outlined about taking care of bone health in young kids, we know we do it for the 70 and older or 60 and older, but we actually look at it throughout their entire lives. If someone sees any three of us with a fracture, the pattern doesn't quite look right, doesn't quite fit with the mechanism of the injury, we know to ask these other questions. Hey, what is your bone health? Well, are you due for a bone density test? Or even if you're a 25-year-old who has a bad fracture, we know to look and think, this isn't right. Something else is going on besides this, as well as what Dr. Velde is outlining. So in many ways, we take care of all musculoskeletal issues of the patient, the non-operative, the education aspect. When people think about surgeons, they think all we do is operate. You know, as a very busy surgeon, I've been the busiest surgeon in every hospital I've ever been. I'm actually one of the most conservative surgeons. I think only 1 out of 6, maybe 1 out of 7 or so patients who see me eventually wind up having surgery. And the benefit we have of our expertise, our background, our training, and our continual desire to be up to date and aware of what's going on in orthopedics, we almost can tell patients the likelihood of their need to have surgery. Certain maladies, say a 70-year-old who sees me with arthritis at the base of the thumb, a very common problem, I can tell them of the patients who I see, only 10% wind up having surgery. So we use our other colleagues, as Dr. Velde indicated, the physical therapist, Dr. Russo indicated our other physician colleagues, our rheumatology colleagues, our physical medicine and rehab colleagues, all of which, by the way, are at CCH. They're on a different floor, but it's one building that takes care of your entire medical needs.
I love that. And that's a huge myth you just busted. Because I think sometimes people do think, like you said, you go to see an orthopedist or you go to see a surgeon, and all they want to do is operate. So I think that's a really good point that you made, that that's not the case. You really look at, you know, the way you're sharing it all, I think of you also as like investigators. You know, you're investigating what happened, what are the causes, what are the deep-rooted issues, and, you know, what is the best method of healing. So thank you for that. Dr. Russo, do you have any myths that you can bust for us today?
Sure. I think one of the things also is about pain control, and especially over the last couple of years with the opioid epidemic, and a lot of the media sensationalizing what has been going on, especially from a pediatric perspective. I think we use a lot of multimodal pain techniques. So we work with our PM&R colleagues to, like Sam already kind of alluded to do some non-op things, but also in children we use things like Botox and stretching that will kind of obviate the need for pain control right away. In terms of post-operative pain control, we like to use NSAIDs in combination with narcotics, and also sometimes with muscle relaxants to decrease the need for narcotic medication. Also simple things, just education about icing and elevating, and the importance of physical therapy and keeping moving, I think are important and something that we emphasize. So, we're not just pill pushers. Very rarely are we prescribing narcotics, and we really like to use all the tools we have in our armamentarium for that.
That's an important concern that you just really clarified. Is you're right, the opioid epidemic is a horrible thing, and people shouldn't assume just because they're going to see you that they're just going to be put on a med, that there's a lot of different options to be able to control pain. Thank you for that. Dr. Velde, is there something you'd like to add that you know is a myth that you could bust for us today?
I would like to add on to the pain control as well, that first of all, the last thing we often offer is a surgery, but when we do offer it, we have a whole team of anesthesiologists here in the hospital who are trained in the latest possible blocks. So any surgeries performed will be with the least amount of pain during surgery, but also afterwards. So when I do, for example, ACLs, rarely do patients require more than a few days of narcotics. constipation is more painful than a knee pain. And so I'd rather not see patients come back because I don't know how to treat constipation.
That's not your specialty.
That's not my
Well, that's good to know. Thank you so much for that. So my next question for you is, what is it about CU Orthopedics that are so special and unique? Dr. Kadiyala, you want to take that first?
Sure, I'll be glad to. I mean, in some ways, it's self-evident. It's Columbia University. And with it, we get all the benefits of the expertise we have. Our department, I believe, is either the 4th or 6th ranked orthopedic department in the country. We're top notch. And all of us are fellowship trained. All of us have different interests. Dr. Russo is fellowship trained pediatric orthopedic surgeon, has become a mentor and a guiding influence for young surgeons coming through our residency program, or younger students want to become orthopedics, and actually become a quite valuable mentor to women in orthopedics, helping guide them at the younger stage of their careers for a very underrepresented portion of our specialty. Dr. Vandervelde and I have had 3 fellowships in our training, so we all have these niches as well as the ability to know all of orthopedics. With Columbia Orthopedics, we are doing more than just clinical work. We're teaching, we're advancing the science, we're doing research, we're publishing, we're giving lectures around the country and around the world. So the way I like to think about it is what Dr. Vandervelde indicated earlier. We're up to date. We're at the leading edge of these things. This is not a situation where we do the same surgery now that we did 15 years ago, because that's what we did 15 years ago.
Thank you. So important, the research, having access to that, teaching, all those things really keep doctors ahead of where things are moving. Dr. Russo, can you share a little bit with me about your experience with Columbia University and the uniqueness of it?
Sure. I think that kind of an unofficial mantra or motto is this idea that complacency leads to stagnation. That we're just not going to accept that. And if our, CVs don't look different from year to year, and if we are not going to meetings and presenting on the, the next topic and more research in that area, then, we're doing something wrong. We want to be educating our residents, our house staff, the support staff that works with us as well, to really make sure that everyone stays at the top of their game and knows, what is going on. And I think Brooklyn really lacked the facility to do that for a long time. Methodist is the oldest hospital in Brooklyn. It's really crazy how long it took to get kind of these state-of-the-art facilities, but New York, everything's about location and real estate. And I think we have really been fortunate now that we can complement the things that we really believe in through Columbia University in the facility that honestly is more state-of-the-art than Columbia is these days, as people who have operated in both places.
That's fantastic. They say 50 is the new 40, the years of Brooklyn Methodist, they're the new young ones for sure with all this cutting edge technology. Dr. Vandervelde, anything else you want to share?
I think I'm new here. So for me, I didn't know the politics of one versus the other. I just looked at Brooklyn and I just started living here.
How do you like it?
It's a beautiful place. Love it. But so I'm by training I'm a clinician scientist, so I like to do research. I'm an academic physician, and so I appreciate having the Columbia University affiliation with all the resources at my disposal for any kind of feedback, any kind of research I would like to do, as well as I can call up any of my colleagues from Columbia at Manhattan when I have a question about anything. But at the same time, I can basically build up my academic practice right here in Brooklyn. So anything I offer is evidence-based. I cannot come up with a single reason why anyone would cross the river. Everything that's available in Manhattan is offered here. I don't do spine, that's my only thing. But anything lower extremity from like I mentioned before, from uh, ligament reconstructions to hip arthroscopy to osteotomies, the whole spectrum that you would think you have to go to one of the bigger academic institutes across the river. It's all done right here, and it saves you the trip across the boroughs, but also more importantly, the whole network of physical therapists, physicians, they're all right here. So we're part of a local community offering the academic care right here.
And it sounds to me too, the extraordinary breadth and scope of all of this is also very appealing to doctors like yourselves who are the best of the best and could be anywhere. And you choose to be there because of these reasons. Is there, can you tell me a little bit about I know there's some affiliation with the Yankees. Who can speak to that for me?
Sure, I'll take the first whack. Yes, we are the team physicians for the Yankees. Our partner, Christen Russo, is their team physician. So all of us, many of us act as consultants depending on, say, what the body part, if a hand or wrist, then I might be contacted, our spine colleagues, etc. But it goes beyond the Yankees. We cover about 6 or 7 universities in the area, and well over 24 high schools in the area with our sports surgeons as well as our non-operative sports physicians in the Columbia family. So it is something that is obviously a big part of orthopedics, and you have the expertise because what we do to take care of the professionals or Division I athletes, we also take care of our younger patients and our recreational athletes. Elizabeth, one thing if I can also add, one of the benefits about being affiliated with Columbia, well, Sam and Kristen, I completely agree with. We take care of everything comes our way because we can do it here. That rare instance where something shouldn't be done here, and I'm thinking of more cancers involving the bones or oncology in that manner, our partners are right there at Columbia. We can facilitate those transfers. Or if it's a very sick child or adult for whatever reasons, some of the specialty care that can be done at Columbia, all 3 of us operate there. On my 3-month-old babies who I have to do a nerve reconstruction after birth, we do it at Columbia. Dr. Russo, again, on those smaller, younger, or patients who aren't as healthy, we operate at Children's Hospital. So all this is available to us while we hope to stay in the borough and do everything there for our patients. If you need to go across the river, we'll go with you.
Wow, that's fantastic. That doesn't matter. You don't have to be a Yankee to get top class service and treatment. So that's wonderful. Thank you for that. I just want to do a quick bounce to each of you. I always love to ask, if you were talking to like your friends, your family, and you could give them one bit of advice about orthopedic care, what would that be? Who would like to go first? Dr. Russo, you want to?
Sure. I would say don't be afraid to ask. You don't know if you don't ask. And, a lot of patients come to me and they think something's wrong. And similar to what Dr. Kadiyala was saying, my surgical indication rate is very low. And I'd say I give good news rather than bad news a lot. So if you're losing sleep over it, or, if your pediatrician wasn't thorough and you think you want another opinion, just come and ask. And most likely you're going to be told everything is fine and everything is normal. And that's a good thing. So just, we're here for those, things that you may not think are important. And God forbid something is, wrong, we catch it early and we deal with it right away.
Fantastic. Dr. Van de Velde, what would you tell your friends and family?
Just stay active. And if you can't stay active for some reason, just come and see us. And then we'll see why you can do what you want to do.
Wonderful. Great advice. And finally, Dr. Kadiyala, what would your advice be?
Well, I think one bit of advice that I would probably give is that what is our goal? Our goal is to restore your function back to what it was before, or as high as we can get it, non-operatively or operatively. That's what we do. If you look at the success rates of orthopedic interventions, we're up there. We're in the 85 to 95% excellent outcomes for every surgery we do. If we're not, then we know we're not going to do that kind of surgery. So it's what I always told my colleagues who ask me, why do I like orthopedics? Say, we win. Aaron Judge, if he hits 310, he's doing outstanding. Well, we're up there 92.5. So our job is to restore your function, and we do it quite well.
That's wonderful. Thank you so much. I actually shared in the chat for more information or to make an appointment, a phone number, and that phone number is 718-246-8700. We are going to get to some of your questions, but I did want to everyone to know that you'll also get an email tomorrow with this phone number too. So I think, what they all said is, let us help you. If you have a concern, if you have a pain, if you have lack of ability to move and function as you wish, don't wait. Get in touch with these doctors and visit them and speak with them. So let me get to some of the questions, because we do have some great questions from our attendees. From Norman, what is the best medicine or exercise for a pinched nerve in your leg radiating from your back? Is there a best medicine or exercise?
I'm probably the only one of these guys that sees back pain. I don't know if either of you do. And I don't see a lot of pinched nerves in kids, but I think the most important thing is to get the right diagnosis first. So to see somebody, whether it's an orthopedic surgeon or a non-operative specialist, and usually starting out conservatively. Anti-inflammatory medications, physical therapy, maybe further imaging. And then if all of those things fail, moving on to more invasive processes if need be.
I think you make a good point. Go to the doctor. Actually see someone and find out about it, because everyone is unique and different. Gloria wanted to know, what are the non-surgical procedures to relieve arthritic knee pain?
I think Dr. Velde could take care of that question quite adroitly.
So this is where I will work closely together with my colleagues at the rehab center, the PMR. So we will first determine the degree of arthritis. So again, what is the diagnosis? How far along are we? And then if there is room for conservative treatment, it will range from physical therapy. So again, stay active. The worst thing you can do for any arthritic joint is to have it stiffen up. So stay active within the allowable pain range. Modifications of gait, so your physical therapist will help with that. Weight reduction, anti-inflammatories, occasional injections to decrease a flare-up of inflammation will help. All the way up to the next steps of seeing, like, do we hit a wall? Is there, after months, do we need to reconsider something? So this is where I work, again, closely together with my colleague, because he takes care of the patients, and then we do clinic together, both here at Kings Highway as well as CCH on the same day. So if a patient sees me and I say, well, there's a lot of room for non-operative treatment, patient can be seen the same day by my colleague, and the other way around too. If there is a displaced meniscus there, which no matter what kind of physical therapy is being applied will not get better, I see the same patient then in my office, and we can move forward with fixing it.
It really is important to uncover what is causing the pain, so that you can make sure that you have the right way to be able to relieve that pain. Terrific. M. Ting wanted to know, can people suffer from osteoarthritis get help with you all and at your hospital?
Yes.
I think the answer is a resounding yes. Much of what we deal with, particularly once we hit the age of 30 and over, are these, what Dr. Vandervelde was describing as degenerative problems, or just a synonym for osteoarthritis. So be it the non-operative treatments, the surgical management to preserve your joint function, sort of to the end stage of joint replacement, be it hip, knee, we do shoulder, elbow. whatever problem we have. So definitely that's well within the armamentarium of what we take care of as orthopedic surgeons.
Terrific. So that you heard it here. So make sure you make your call and you get your help for sure. George wanted to know of the three of you, who it would be best to see in regard to hip replacement surgery.
Well, I'm going to start with that because Dr. Vandeveld is probably going to be too bashful to say me. So I am a fellowship trained hip and knee replacement surgeon, but I am deferring to my younger colleagues who do this in a different way than what I did for 3 decades in the way I trained. Specifically, Dr. Vandeveld's an expert in what we call an anterior approach to hip replacement. Think of it as the goal is preserving your muscles the best we can around your hip joint, so you have a faster recovery and better outcome because your soft tissues are pretty much back to normal almost immediately.
Okay, Dr. Vandeveld?
Cannot really add a whole lot to that. The other reason I like to do the anterior hip approach is because, again, coming from my pediatric background, I deal with the sort of more complex primary hips in patients with hip dysplasia where the anatomic landmarks are not always as obvious. So each patient is treated again as an individual, and using the anterior approach, I can use fluoroscopy, which is basically low dosage X-ray imaging during surgery to determine the optimal placement of the various components of the total hip. And again, you go through the tissues as if it's a child, and you're careful with it, you handle them with care, which in the end leads up to a better recovery.
Fantastic. Now, Dr. Vandeveld, can you share a little bit about, what hip preservation is, and is that what you're describing, and why is that helpful for younger athletes?
So hip preservation is traditionally was thought of as a bridge between pediatrics and the adult arthroplasty joint replacement surgeons. Even though currently, when we speak about hip preservation, the anterior total hip replacement is sort of becoming part of it, just because we're dealing with the whole spectrum of the hip. But so the mainstay of hip preservation will be hip arthroscopy, which is done here at CCH, the outpatient clinic. So any patient with a bump on the femoral neck, a cam deformity, any labral tear, can usually be treated with hip arthroscopy, which is keyhole procedure. Patient comes in the morning and leaves the same day and sleep in their own bed. In case that the hip joint itself is not aligned well, mild hip dysplasia, any malposition of the femoral neck, hip arthroscopy will not be sufficient. It will actually do more damage than good. And so that's when I will offer osteotomy, which is dividing of the bone around the hip socket, so-called periacetabullar osteotomy. It always sounds like a scarier surgery because it's big bones that need to be divided, but the patients after the initial weeks after surgery recover really well, and your joint is put in the exact position where it's supposed to be. And by doing so, I can usually, on average, postpone the need for a total hip replacement by 20 up to 30 years.
Wow. I'm amazed hearing all of this. I mean, it really is extraordinary what you all do to help people and allow them to lead lives that allow them with the activity that they wish to have. Norman has a question. I'm not sure if this is orthopedic, but he wanted to know what causes leg cramps when you're sleeping. Does this have anything to do with orthopedics? Or is that more of a nerve issue, you think?
Norman, that's a hard question to answer as someone who's now approaching that stage in life where it's going to start happening. What causes it? Usually we think it's typical leg cramps. It's more of a vascular injury, blood vessels. How the blood flow goes to your calf muscles and so on, that's typically where it occurs. It can be nerve mediated, so that's why a visit with your physician, your primary care physician, to talk about what exactly is bothering you. So the problem, once we find out what the diagnosis is, then we sort of steer you, how do we treat it? Unfortunately, those classic leg cramps, there's really not a great solution for. Some of you may remember that we used to give quinine for it back in the day. It's no longer available to be given to patients. So it is something that we try to emphasize the other aspects of your care: exercise, losing weight, staying active, staying flexible, because there's those things we can address. Certain things like your blood vessels, we can't necessarily take care of or fix.
Thank you so much for that. This has been incredible. I am so grateful to each of you, Dr. Russo, Dr. Kadiyala, Dr. Velde. Thank you so much for your generosity of information and sharing all this with us. We've certainly learned a lot about the extraordinary work that you're doing at New York Presbyterian Brooklyn Methodist Hospital. And as I said, I am sharing the information on how to make an appointment and call for more information. I know any concerns I would have had to come to see an orthopedist are completely gone, and understanding all that you offer and all that can be healed and feel better is so important. So don't delay, reach out and find out what's going on so that you can start to get on the road of healing. So again, thank you so very much. I want to thank our attendees for joining us and spending some time with us this afternoon. You will get an email with a recording of this so you can watch it again. You can share it with your community. You'll also get an email that provides you with the phone number too, if you did not write that down. And I wish you all to have a wonderful day. Please, everyone, stay safe and stay healthy. And we'll look forward to seeing you on a future webinar. Have a great day, everybody.